and what you can ask your doctors about and talk about. So I think I was going to say just really quickly about myself. I'm a naturopath. I've been in practice since 2000, and I'm in North Bend, Washington. And I think, are we missing someone? Someone?
Nope, I just muted somebody because I was hearing
Oh.
background noise.
Um, anyway, and so and our my focus in my practice is women's health. So I do a lot of care of women of all ages, but menopause is near and dear to my heart, and it, as we've talked about last time we did this, is kind of having a moment, and I think it's becoming really, really much more popular. The idea of options for women, that there are options for
Imagine
getting
that.
people through menopause. Yeah. Okay. And hi, Lynn. I know you're muted, but you were the person I was worried about not getting let in on time.
She's
So
in.
she's
She's
in.
in.
We're good.
Okay, and I'm Dr. Busy Riley. So just want to clarify we're in Washington State. I know some of you are not in Washington State, and Allie is a naturopath in North Bend, and I am a naturopath in Issaquah. And even though I knew about her for a long time, we actually didn't meet until maybe like 5 or 6 years ago. And it's been such a gift because we've both been kind of in small independent practices doing work with our heads down, seeing women going through all kinds of hormonal transitions. And it is really interesting that hormonal transitions are having a moment now. And I think one of the things that Allie and I have been struggling with is seeing that there's a lot of misinformation, a lot of fantasy out there. And as naturopathic doctors in primary care, we already struggle with navigating that a lot. There is a lot of bullshit out there, if you don't mind me saying so, that we actually kind of have to try to give clarity on. And I think it's awesome that there's so much information about hormonal transitions now, but it also means that there is more and more and more information that we're kind of having to navigate. And we want our female patients, we want all of our patients to thrive, but especially our perimenopausal and menopausal women. We really want them to thrive and make the most of this transition and end up in a better place. But we don't necessarily want to sell them a fantasy in order for them to do that. So that's kind of where this started for us, as we started having all these conversations about how nuanced these transitions are for people. And so, really, what we wanted to focus on today was metabolism. But because we're going to be talking about metabolism, because I'm pretty sure most women out there that are perimenopausal or menopausal at some point have been had questions about what the hell is happening to their bodies in some way, shape, or form. But in order to talk about metabolism, we really have to talk about stress and stress hormones. So I'm going to start off with a little bit of a definition, and then we're going to move on from there. While we are talking, I want you guys to feel free to enter any questions in the chat. We can totally address those as time goes on, and it doesn't necessarily have to be metabolism related. So I'm going to share my screen again. Now, I think you guys probably remember from last time that I'm not very tech savvy. Look, I literally don't even know how to change my slides back. Okay, hold on one second. Escape here, slideshow. Okay. I would like a silent round of applause for the fact that I matched the background color to the Hot for Hormones logo. Okay, so here's where we want to start. This is what I really want to emphasize when we talked about this a little bit last time. A lot of what people talk about as perimenopause is not perimenopause. The official definition, and this is a 2021 um, stages of a reproductive aging workshop where actually we got official definitions for these things, or they were agreed upon. Perimenopause starts with a variability in your cycle length of more than 7 days in consecutive cycles. So if you are not having, if you're not having cycles, that's a whole other issue. But if you're having cycles that are regular, a lot of women come in and say, I know I'm in perimenopause. They're having regular cycles and terrible, terrible, terrible PMS, hot flashes and night sweats with their PMS. That's not perimenopause. That's likely stress, which we're going to talk about. So the early perimenopausal transition is with this cycle variability that's more than equal to or more than 7 days of change in the length of your cycle with consecutive cycles looking like that. Later perimenopause is when you are missing cycles for a period of more than 60 days. So
Put
I
some more
just
so I can focus.
say that again. Oh, okay. If there's a question, Allie, is there a question about that in the chat? I think that was just
No.
maybe someone in the background. Okay, so have that definition down. So here's what I really want to talk about and to lay the groundwork for this, and then Allie's going to talk about this also. This is a very complicated flow chart, which I will walk you through. But the point of this, please again note that I put these arrows on this slide and I'm very proud of myself. Let's pay attention to the arrows. So the big things I want you guys to think about are this is cholesterol. So all of your hormones are made from fats, your estrogens, your testosterone, your progesterone. All of these things are made from fat, and cortisol is a stress hormone that we make every single day in a nice cycle where it's high in the morning and low at night so you can sleep. But we make more cortisol in order to meet the demands of stress. And the problem is that as we approach perimenopause and menopause, a lot of us are really, 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 really stressed. And so our demand for cortisol is high. So basically, your body is going to be manufacturing all of these hormones from the same pool of fat, but it's going to preferentially choose the ones that we need for survival. And because we're still animals in our brains, a lot of times we will preferentially make cortisol instead of nourishing, like over here, the estrogen, the testosterone, and the progesterone. Progesterone is what nourishes that second half of your cycle. So if you have a lot of PMS, a lot of times for women, that is because of progesterone deficiency. And if you're high stress, a lot of times that's because the cortisol demand is so high that it's pulling from the pool of progesterone that is available to nourish your premenstrual time. Okay. So just wanted to put that out there. And then I also want to show you how do you, okay. I also wanted to show you this, which is basic cortisol physiology. So this is what a natural cortisol curve should look like. Nice and high in the morning, nice and low at night so you can sleep. When you go through really stressful phases of your life, so let's say like getting up to take care of a baby or caring for an elder, or just like work is so demanding, you're waking up thinking about it all night. A lot of times what happens is you're making a lot of cortisol at night and it can throw this whole system off. So when we talk about metabolism, the reason that cortisol comes into play is that cortisol is designed for periods of starvation. We are animals. I really want you guys to hear me say that. We are primitive animals with refrigerators and heaters. And so when we are stressed and we're making cortisol, cortisol is sending the signal to your body that's like, winter is coming. We have run out of food in our cave. We're going to have to move our herd, or move to follow our camp to follow the herd, put it all in as belly fat and store it because we're going to need it later. So that is like one of the biggest things that happens with cortisol and metabolism around this time frame. Allie, your
Yeah.
thoughts?
Okay, so first of all, we had a really great question. Somebody asked, is there a way to test
Mm,
cortisol? And there is, and that's a great question. And it's something that I think naturopaths do better than conventional medical doctors. And here's the reason. Most conventional medicine is very black and white. You're either in the range or you're out, and that's it. And cortisol can be drawn in blood work, but it's just the point in time that the blood came out of your body where we're looking at cortisol. So you can do a morning cortisol. You could even do an afternoon cortisol in your blood, but those are just two data points. And a lot of times those don't really elucidate what's going on,
mm,
because that if you go back to that graph that you had up busy, it starts high in the morning and goes low at the end of the day. So especially if you're just spot checking a morning cortisol, morning could be somewhere in the normal range, but then maybe it stays high all day long, or maybe it plummets right after that and goes abnormally low, and you're not going to pick that up on a blood test as well. So one of the ways, well, the only way really that I do it is by a salivary test, which is not some woo-woo naturopathic thing. That we've realized that some hormones are really good to look at through salivary source, and you're seeing bioavailable amounts of cortisol that way. And then you can have the patient test morning, noon, afternoon, and night, and really get a much better idea of what's happening with cortisol. And when it becomes irregular, like I said, you can feel crappy if it's high all the time. You can feel crappy if it's low. And because cortisol has a really integral role in what blood sugar is like, it also really helps guide what we need to do to support metabolism if we know what is happening with cortisol.
mhm. Yeah, definitely. And the test is not expensive. It's like $150 to do the salivary test, so it's really helpful. So cortisol changes everything about our metabolisms, right? And the majority of us tend to be stressed at midlife, right? Like we have kids that are at a stressful age. We often have aging parents. Our careers are at their pinnacles. So it's really common for people to be making a ton of stress hormone. It disrupts our sleep. It causes us to gain belly fat and kind of makes us feel like garbage also. So one of the number one things that we talk about for our perimenopausal and menopausal patients is learning how to cultivate relaxation, which a lot of us by the time we get to midlife have completely lost our ability to do that. And I kind of joke that it becomes this impossible task as we're going into menopause. And we certainly see women like before this phase and long after this phase because we're basically trained, especially as working women, especially if you're a working mother, to like ignore your needs. Like you run on stress, right? Like stress is your commodity. And I feel like for myself and for a lot of my patients who are going through this transition, I am literally the best thing you can do for your metabolism is to learn how to cultivate relaxation. And that's a pretty tall order for a lot of us, right? Because a lot of us really have like completely lost, we have lost the ability to do that. We have four email addresses, we have four social media accounts, we have a phone, a computer, a laptop, right? Like we're constantly being bombarded with information.
Izzy, there's a question
Yeah.
about the Dutch test and how you
Yes.
feel about that. Do you
Yeah.
want to take that one first?
I don't have feelings about it that are super positive.
Oh,
No,
good.
I
That's what I
the
typed. I said I actually don't love the Dutch test.
yeah.
We can discuss.
I think it's more so with there are a lot of different testing mechanisms, and this is one of the things that with menopause and perimenopause is really tricky because women, most people like data. Like we want to have a test that says this is exactly where you are. I think a lot of physicians, and I don't think this is true of everyone, but to be honest, I do think people make money on the Dutch testing. I think they use it as a tool in order to prescribe supplements and hormones. And then basically you're caught in this cycle where you're paying to repeat the test in order to change or adjust your supplementation or your hormones. And I really do not feel that's necessary for myself. And I think, Allie, you practice
I
the
do.
same way that I do.
Yeah, I think that's really well said. I think it's superfluous both in the amount of information it gives you. It's not clinically necessary to look at all of that
Yeah.
information.
Yeah.
And it doesn't guide my clinical thinking for me. Um, and I think that there's a lot more affordable ways to look at adrenal hormones than to do the Dutch test. So that's the adrenal hormone piece is just one part of the Dutch test. And that might be useful, although I didn't actually realize because I don't use it for lots of those reasons, that the person who asked the question said that the Dutch test, I guess the cortisol is measured from urine, and that I don't think that's as accurate as salivary hormone testing for cortisol. If you think about, you're looking in urine, you're looking at metabolites. So there's a little bit of a difference there. There is some data with regard to like estrogen breakdown in urine,
Mm-hmm.
and looking at estrogen metabolites,
Mm-hmm.
especially for people who are really either have had breast cancer or at a very high risk for breast cancer, and we're trying to optimize like urine metabolites. That is actually one thing that is good to test in urine, but I don't think that cortisol is that urine testing is the best source for cortisol.
Yeah. So one of the things I wanted to emphasize about cortisol, and I would say this is true in perimenopause and definitely more true as we get into menopause, which means you have gone more than 12 months without a menstrual cycle, you are no longer ovulating, is the concept of exercise and metabolism. And I think this is pretty well talked about, but I really want to emphasize this because I have a lot of patients that come in that have been doing the same kind of exercise their whole life, and all of a sudden they get into menopause or perimenopause and they're just gaining a ton of weight. And so one of the things I really want to talk about is the difference between cardiovascular type of exercise and muscle building and weight training kind of exercise. If you're one of those people, this may be kind of familiar to you that if you're a runner, if you're like a distance runner or hiker and you love to do a lot, or you're like someone that loves to be on the treadmill or you love to be on the Stairmaster, what we tend to find at this stage of life is that especially if people are feeling a little bit more depleted, if your energy demands are a little bit higher, if your sleep is disrupted, those types of exercise require much more cortisol in order to do the exercise. So if you think about it, you're making cortisol, which is basically telling your body to store every calorie as fat in order to do the exercise where you're trying to burn calories to keep like your caloric balance intact. And so that's a really, really tough concept for some of us who really love our cardio. But it is something that I really want people to be aware of, that I'm really encouraging my patients to do some kind of weight training. And that does not mean that you have to like go to a gym and like get super muscular, but not only do you start to lose your muscle mass and your bone density when you go into menopause, so you need to be doing some kind of hard exercise, but also building muscle means you're building mitochondria, which are like the energy producers of the cell. And that is really where the magic happens with your metabolism. So it doesn't mean you can't do cardiovascular type of exercise, but like I'm curious to see what you say about this, Allie. For me, with my patients, I usually say like two weight bearing exercises per week and then two times something cardiovascular. That could be, depends on your energy, it depends on your fitness level. So that could be like you're walking for 30 minutes. Some people, if they're already walkers, I'll tell them to just buy a weighted vest. So keep doing your walking and add some weight to it. If it doesn't feel kind of hard, it's not something that's going to necessarily stimulate your metabolism. And we want our metabolisms to be flexible, right? Like we don't always want to have a super fast metabolism. We want to be able to enjoy our bodies and do different things with our bodies. And that means metabolic flexibility. So not doing the same thing at the same pace all the time.
Yeah.
Thoughts, Allie, thoughts on that?
Yeah, I agree. I think that the big change that you already highlighted is trying to maintain or even increase muscle mass so that metabolism is turned on. And yeah, my rule of thumb is four hard uh, exercise sessions a week, with at least two being weights and but moving like most every day, not having, I mean, if the goal is weight loss,
Yeah.
having movement most days, but for hard workouts.
Or weight maintenance.
Yeah, yeah,
And so, and I also really want to reiterate, and we will definitely talk about the supplementation. So, you guys are asking great questions about supplements, and we will get into that. But before we do that, because this is our job, is to work on foundations of health, I cannot emphasize enough that there are no supplements that take place of the lifestyle factors that you need to have in place for a healthy metabolism. Like, and it's not just because everybody needs to be lean. It's because those are the things that actually are going to feed your health in all these other areas. So like the sleep thing is absolutely mandatory. And guess what falls apart in perimenopause and menopause? Like most of us really struggle with our sleep during those phases. I cannot emphasize enough how important it is to get yourself sleeping a minimum of 7 hours. A lot of my patients that are like, go, go, go people, and they're like, I can get by on 6.5 hours. I find that when they get into menopause, that just doesn't end up being enough sleep for them. So, sleep is mandatory. Working on your stress level, making sure that you are capable of cultivating relaxation. And that, again, it doesn't mean that you have to like sit down and meditate every day quietly. If you can, that's wonderful. It could mean that you're doing 5 minutes of breathing exercises. It could mean you take a slow walk. It can mean you get on the phone with a friend and you have like a joyful moment where you're not looking at screens. So that can look really different for everyone. Um,
I'm just going to add one other piece, and then it looks like we have so many questions about that I want to make sure we
yeah,
get to. But
let's do it.
the other thing that I tell people to pay attention to is if they feel more depleted after they exercise, or if
Mm,
that exercise really makes them feel good.
yeah,
If
good
you
point.
are doing something to the extent that you feel like you have to have a nap after you do it, or it just really was wearing you out, that to me, in and of itself, is a clue to look at adrenal hormones and adrenal function.
Yeah.
Because I think that uh, exercise shouldn't make you feel like you need to just go to sleep, like it's that depleting.
I agree with that. And the other thing that I would say about that, especially when it's a lot of muscle soreness, which I'm about to talk about protein, which please take everything with a grain of salt. There's so much controversy over how much protein everyone should be eating. It's one of the funny things in that video that I put in the chat where she talks about eating like as many grams of protein as there are stars in the sky because it kind of becomes a full-time job. And but if you're getting really sore when you're working out, if you're using your muscles, but you're not getting enough protein, calories or some of the micronutrients you need, that could be one of the reasons why you're getting sore. And so everybody has a different ballpark for how they like to do this. If someone's trying to maintain muscle, I tend to say 1 gram per kilogram of body weight. So that's basically like a little less than half of your body weight in pounds. So let's say like if you're 160, that would be about 80 grams of protein. And that's a low ball for a lot of people. A lot of people will do 1 gram per pound of body weight. I literally do not know how that's humanly possible because that is a full, I love protein and I find that really, really challenging. So what do you recommend to patients, Allie?
Yeah, again, depending on whether their strategy is for weight loss, but if it is and they're menopausal, my goal is to get somewhere around that amount too.
Yeah.
The highest I usually recommend, no matter what the person's weight is 100 grams, because I
Yeah.
think beyond that, it's almost impossible to get. I mean, that's getting 25 grams and in four spaced in
It's a
four different.
lot.
So
It's a
that's like
lot of
three
work.
meals with a good protein
Yeah.
and probably some sort of shake or something
Yeah.
that is a low calorie, low fat food, but that gives you a high amount of protein. That's
Yeah.
about as high as I think is reasonable to expect that anybody could do.
Well, and I also start to wonder at that point, like, what are our bodies designed to do? Like, I just don't think we're designed. I think nobody 1,000 years ago was eating that much protein. I think our
Mhm.
bodies are designed to do hard work. I don't know that that necessarily means that we have to eat our weight in protein every day. Like, that just sounds insane to me.
I agree. And I think that the rationale behind it really is so that if you're in this stress hormone and sympathetic dominant state where cortisol is higher than we want it to be,
Hmm.
you're mobilizing a lot of blood sugar
Yeah.
or sugar from stored areas and putting it in the blood. And so it's really it's less about that we're designed to eat so much higher protein than we normally do. It's really the metabolic trick to
Yeah.
try to undo that vicious cycle of having high blood sugar stay high all the time and then kind of storing everything as fat.
Yeah.
So yeah.
And
So
I just want to answer this. Yes, Wendy, plant-based proteins totally count. And the only caveat there is that if you're a vegetarian, if you're supplementing with protein, that is just isolated protein, whatever the source is, if it's pea protein, if it's soy protein, if it's whey, whatever, that's just protein. So yes, absolutely plant-based protein counts. If you're vegetarian and you're trying to get your protein from a vegetarian source diet, you do need to remember that that's going to be a much higher carb diet. And so I do tend to encourage my vegetarian patients to supplement a little bit if they're struggling with their blood sugar control or if they're struggling with their metabolisms, because it's a lot harder to eat like a lower carb, high protein diet if you're eating vegetarian sources, just because of the nature of that food. It's a lower protein type of food. Um,
okay, so
do you want
going
to hit
back
some
to
questions?
some of the questions, yeah, any natural metabolism boosters to recommend?
No.
Yeah,
Not really.
I don't
I
have any
really think it's
either.
all
There's,
bullshit. I think
yeah,
it's
I
all
do too.
bullshit.
Instagram has this one,
Ugh,
not to pick on anybody, but there's probiotics now that are supposed to work like GLP-1s. I have not found those to be clinically very impressive.
nope.
I forget the name of it right now, but there's this supplement that was really popular for a while that was like turmeric and a probiotic and one other thing. And that I don't feel like works. Garcinia is an
Yeah,
herb that gets promoted, and I just don't find anything to be a real wow factor.
yeah.
Certainly, if you have a subclinical thyroid problem, or if your adrenal hormones are out of whack, then indirectly there are herbs that can help manage those things, which
Hmm.
then could help translate into better metabolism. But just straight like, take this, it will boost your metabolism. There's just really not anything that I can stand behind.
I think it's all total baloney. I will say, I know that Kelly put a question there about creatine powder. I think that for people who are already doing the exercise, so like you're strength training twice a week, you're moving your body, I do think there are things that can help you build muscle a little bit more efficiently. And I do think that some people respond really well to creatine, and I don't use it for everybody. There's some awesome data coming out for about creatine with cognition, using it for people with chronic fatigue, and some of my chronically fatigued patients really like it. So I always think it's worth a try. And I use about 5 grams a day for people. And I do tend to caution people if you have anxiety to just start small, smaller than 5 grams, and work your way up, because some of us have kind of lost our goddamn minds on it accidentally. So just be careful if you do use it. But I do find that it can help a little bit if you're already doing the work. And then the other thing supplementally that I would really pay attention to is, again, if you're not sleeping, that's where I would supplement someone. If you're exercising, really, you're doing all the exercise, you're eating all the food, you're doing all the thing, but you're not sleeping, that is where I would supplement you. And if your adrenals are messed up, that is definitely where I would start supplementing you. I think the metabolic supplementation is absolute baloney. I will tell you, and I'll try to find this before the end of the podcast, the end of the Zoom, there's an awesome podcast by some naturopaths down in Portland. It's all about poop. They all focus on gastroenterology, but they did just do a really interesting one about the probiotics that made me consider revisiting probiotics for metabolic support. The hard thing is that we have a lot of data showing that people with, certain metabolisms have this certain strains of probiotics in their guts, and people with other types of metabolisms have the other strains. We don't have data showing that if we take the strains from the leaner people and put it into the guts of people that aren't as lean, that suddenly changes their metabolism. So, like, correlation is not causation, right? So we don't necessarily know how that works yet.
Yeah.
Yeah.
Yeah. Great. I just was mentioned, somebody said they started shifting to dancing from running. I think, again,
Hmm.
that goes back to like, you do, I think, need to not just continue to hammer the same thing and expect the same results, whether it's like your knees may not like running anymore,
Yep.
or, if you're having pain with the exercise you're doing, it's time to look at doing different things. Getting stronger, though, because muscle mass decreases, I think getting stronger is a super important part
Yeah.
of being able to continue to be active. Okay.
I
And
would
then,
add one thing to that too, just really again wanting to emphasize that there are sort of like two classes of exercise that I think about at this phase. There's the movement, like I don't want to discount walking as important exercise. Like I think walking and dancing and all those things are wonderful, because I actually think part of why they're good for our metabolisms is they cultivate relaxation and joy and community, which is really, really important. But I don't see people easily in this phase maintain their body mass, or like maintain the body that they want to be in, without doing something that's a little hard. So just remember, it doesn't have to feel bad, but some people that aren't used to exercising, they do not like how it feels to do hard exercise. And I think that's what our bodies are designed to do. Like it has to kind of like surprise your metabolism a little bit. So I just want to reemphasize keeping it diverse is really important.
yeah.
All right, what do we
Um,
got? Bone
what
density?
kind
Oh,
of
yeah.
foods do you encourage?
Hmm.
Do we think
Foods?
collagen is
Oh,
effective? No,
Allie, how do you feel about collagen?
no. I shouldn't, I don't want, I would never want anyone to feel bad, but I inwardly cringe when I hear that word, because I just feel like it's another one of those things that has gotten so much traction for no real
Yeah.
clinical benefit.
Well, I take collagen every day. So, and I'm not offended by you saying that. And I take it because it's a really easily absorbable form of protein. It's
Yeah,
not because, look at I'm so wrinkly, like it is not helping me make collagen. And there's
right,
no evidence that taking collagen helps you make collagen. It's such
right.
bullshit. There's no evidence. But it is a really, really easily absorbable form of protein. And it works, like for me, I can put it in my coffee in the morning. And by the time I'm done, I have 20 grams of protein. I love it for that. But I think it's
Yeah.
a total hoax other than that.
Yeah. I guess I wasn't thinking about protein sources effective. I think of all the things it's touted for as like, is it
No,
effective? No, but
no,
it is a
no
protein source.
evidence.
It also
Yeah,
is usually a bovine protein source. So I think that there should be some caution as to the
agreed.
quality of collagen that you take in,
Yeah.
whether it comes from commercial cow or, something that's cared for and treated a little bit differently. And also if you have like a beef or dairy allergy, there's cross reactivity there with that kind of protein. So there
And
can be
side
that.
note, if you want to gross yourself out, look up how dairy-based collagen is made. It'll really gross you out. Okay, bone
Bone
density.
density. DEXA, that
Allie?
is an area of osteopenia. Okay, so I love teaching women about this. I'll say this
Hmm.
first. There's two, usually when you get a DEXA, you have two areas of your body that get measured. One is the spine and one is a hip. And the spine is primarily trabecular bone. And that type of bone is really, really sensitive to estrogen and progesterone. So when you're menopausal, you have been for 5 years, if you're not taking hormones, you lose what's called the estrogen packet of bone, and that's where we see a diminished density in the spine. The hip has trabecular bone in it, but also equal parts cortical bone, so it's more representative of cortical bone compared to the spine. And cortical bone is much more responsive to our minerals and vitamins like calcium and vitamin D. So if there's a big discrepancy in one or the other area, I'm thinking about the things that it takes to create that bone, and endocrine problems, stuff like that. And then osteopenia, what we measure in bone density is a standard deviation that is different from a 30-year-old woman. So 30-year-old is kind of like considered peak bone mass if everything has happened right. And then from there, we measure a standard deviation away from that. So if you're 50 or 60, let's say 60, because you're 95% of women are menopausal by the age of 55. So if you're 60 and you have some mild osteopenia, that's not necessarily a disease state. I mean, that's somewhat expected. Now, the amount of bone density loss that you've had, there are lots of nuances to, like, if you're nearing osteoporosis, that is important, and we try to intervene. If you're just barely below the normal range of normal being a 30-year-old bone mass and then get considered to be osteopenic, I don't think that that's necessarily a super big area of concern. So it really needs to be in context of how bad it is, where it is, and how old you are, and kind of all of those things.
And I would add to that, the most important thing is what direction is it going in. So the stupid thing about DEXA is that we typically do not order a DEXA until someone is in their 60s, at which point, like, the fastest rate of bone loss is going to happen in the first 3 to 5 years of menopause. It's a really dumb system. So I'm actually just starting to order it for my younger patients because it's not an expensive test. But there's also a test that you can run. It's called a C-telopeptide. It's a serum test you can ask your doctor to run. And it's actually our marker for your current rate of bone loss. And you want that marker to be low, under 300, because you want to make sure that you're not actively losing bone density. And so I will use both of those tests side by side. And if I have a younger patient that has a really high peptide, I'm putting her on estrogen to stabilize her bones if she's a good candidate. I'm talking about weight bearing exercise. The absolute most important thing for your bone density everywhere is doing different types of weight bearing exercise and making sure your hormones are adequate. And then I'm testing those things serially, like every 3 to 6 months with the blood work to make sure that that marker is going down for her. So those are really easy tests that you could add on. That's not very expensive, to just see what's going on. And I totally agree with Allie. Like, osteopenia doesn't have to be a big deal as long as it's stable and it's not really, really severe. So that is a really good indication for hormone replacement therapy. And even like even a little bit of testosterone sometimes can be really helpful to add on for bone density also. And I did mean to add that earlier when we were talking about muscle and maintaining muscle mass. That is, I sometimes see a tiny bit of topical testosterone really, really helpful for my menopausal patients to just maintain their lean muscle mass. Um, all right, Allie, what do we got next?
Um, what supplements do you suggest for, oh wait, I think I missed one. Hang on. What supplements do we suggest at this time of life?
Hmm.
And any that help with hormone balance or stress relief?
Hmm. So, I have to be honest that I am actually starting to use high quality broad spectrum multivitamins more with my patients at this phase of life. I don't think people need to take them every day, all year round. I do find that a really good quality multivitamin, and I can, like, we can do, right, tell you a little bit about what that means. Even just a one a day that's good quality that has methylated B vitamins can really, really help with detoxification processes, energy production. Like I'm really starting to focus more on the way the mitochondria is working to manufacture energy. So I do encourage people to start a multivitamin, make sure that your vitamin D levels are adequate. And then again, a lot of the supplementation that I do has to do with sleep and the stress hormones. I do a lot of supplementation around stress hormones. The hormone balance is an interesting question, Jenna Glasser. One thing I want to say about this is that if you are post-menopausal, meaning you are not cycling anymore and you are on hormone replacement therapy, we really don't use supplementation for hormones because once you're on hormone replacement therapy, you're like using those hormones and it is a steady state, which is what's so beautiful about hormone replacement therapy. So if I have people that are still cycling and they are trying to get their cycles to be more regulated, I use a lot of herbs and a lot of nutrients. Like I think Allie, you use a certain one. I use Women's Phase One by Vitanica. I use a lot of that product. What's the one that you use, Allie?
I use that one too, and then I use something called FemGuard Balance.
Yeah, FemGuard is the one. Yeah. So there are a lot of herbs that you can use to keep your cycles regulated. But if you're on exogenous hormones, and that's like the birth control pill or hormone replacement therapy, that kind of changes the game. I do like those B vitamins on board for either one of those, just to again help with the utilization and processing of those.
Yeah, I
What about you,
agree.
Allie?
I totally agree. I think that also as we get older, not only does our skin dry. Oh, wait, we have somebody in waiting room.
Oh, sorry. Did you get him? Her?
Yeah, I
Okay.
did. Sorry to the person who was in the waiting room. I'm not sure how long you were there, but hopefully you are able to tune in now. Um, I just think as we get older, not only does our skin dry and our external areas get more dry, but I think our internal digestive capability also is less robust. And so adding more of those vitamins that we need, like you said, for cellular support, which is really, the Krebs cycle and all the B vitamins that plug into making cellular energy. That's what's really important in my mind too.
Yeah.
I'm a big proponent at this point in life of being on omega-3 fatty
Mm-hmm.
acids. I think they're great anti-inflammatory support, good for brain function, good studies documenting mild and moderate depression improvement with omegas. And I always tell people it's easy to eat a heart, well, not easy necessarily, but it's you can accomplish eating a heart healthy diet by having fish a couple of times a week, but you're not really getting a therapeutic amount of fish oil and those omega-3 fatty acids unless you're really using them daily
Yeah, I agree.
as a food source. So I usually like to supplement those. And then I have a calcium equation back to the bone density thing that our calcium requirement actually goes up at this time of life. So it's really important to make sure you're getting adequate calcium, and it's important to not get too much nor too little. So I always go through with my patients, this is the total amount you get. This is how much you usually get from food plus dairy serving per day. You kind of do the math and you figure out what you may need to supplement on top of what you get through your food.
Allie, what omega-3 supplement do you use? There's a question.
I use a couple of different ones. The answer really is that professional brands that are clean source is and there are lots of those, and then also ones that are the most bang for their buck.
That's how
So
I
i'm
feel too.
really i'm really looking for like EPA and DHA levels that are easy to get at least 1,500 milligrams a day or more.
Yeah,
um,
I
and I don't
agree.
want people to have to take 8 pills to get that. So
Yep.
there's one by Designs for Health called Omega High Potency. That
Hmm.
one's good. Nordic Naturals has one. I can't remember what their one is called, like Super Pro.
The
Oh,
one I use by Nordic Naturals, and I'll put this in there, is the Pro Omega.
Pro
And
Omega,
please
that's it.
do not buy cheap fish oil, people out there. It's like you don't want cheap fish oil. That means it's not going to be well processed. It's going to be rancid. It can do the opposite to what you want good fish oil to do. So just if you're going to do it, spend your money on good quality fish oil.
I
I
agree.
think we should address these two questions: sleep supplements, or what to do if you're exhausted in the morning, and how to decide when to start hormone replacement. How do you feel about that,
Okay,
Allie?
yay.
You
Which
what
one,
do you
which one do you want to do?
don't care. You pick.
Okay. I'm going to touch on when to decide. I'm trying to find the question though. When to decide.
It's the question is how to decide when to start hormone replacement.
Okay, so like Busy was saying, there is the period of time leading up to menopause that is pre-perimenopause even. So if you're having cycles that are really, really regular, the thinking is that you're not yet in perimenopause. Your follicle is still producing regular cyclical amounts of estrogen, progesterone, which is lending itself to having regular cycles. So if your cycles are like 28 days, 29, 30, 27, those are all regular enough that you're probably not perimenopausal. But if your cycles are like 17 days and then 35 days and then 20 days and then 38 days, that is more of an indicator that you are truly perimenopausal and that the follicle is not making a robust amount of estrogen and progesterone. So there's two ways to address that. One is to give a low dose birth control pill that just suppresses ovarian function. So it turns off that irregular production that the follicles are now, that's what they're able to do. And that's more of a conventional idea, although I do it and I know Busy does it too sometimes.
Yeah.
But suppress ovarian function, and then you just have the um, monochromatic hormones that come from the birth control to even things out. Or you start using hormone therapy that helps augment your own levels of hormones. And it's not a totally hard and fast rule because I would say that I also sometimes use hormones for people who do have regular cycles,
Hmm.
especially if they're really curious to see, like maybe this is going to help with X, Y, or Z. But I would say the general rule of thumb is in that irregular period time.
Yeah. I would agree with that. I would say there are definitely times when it's a little bit of trial and error when you initiate HRT if you're not officially in menopause. Like most women are coming in when they're starting to have menopausal symptoms that require estrogen support. So like if you're having night sweats or hot flashes all night long, if you feel like anyone that has a penis should be killed, that can be an indication that maybe you need some more estrogen support. Like, there are, your moods are really changing and it's not all, only just part of your cycle. Like, those are indications that sometimes you layer an estrogen patch on there and it can really help alleviate those symptoms. But it really, really tends to be trial and error. And it's about how you feel with each type of hormone. And so I think there's a lot of nuance there. There's no rule that you can't do it before you're officially in menopause. In fact, I would say for myself, and I think Allie, you too, like I'm probably starting to more and more use HRT types of hormones with my patients who sometimes are still cycling. But if you're someone where like your cycles are becoming intolerable, like whether that's because of heavy bleeding or because like your PMS is outrageous or like you feel like you're like just a slave to your cycles, that's an indication that a hormonal contraceptive is probably a really good fit for you. Like you just don't want to cycle anymore, which is the gift that menopause brings us, but sometimes it just takes a really long time for that to happen. So
Yeah.
there's a little bit of nuance in there. There's no one rule. It really is about like what feels like a good fit to you and what's a good fit for the individual patient.
And that's such a good segue into this next question I'll read. It says, why would you need to use hormones, birth control, or
Mm,
HRT? Can your body just go through menopause without?
yep.
Totally. Yes. The answer is absolutely hands down. Yes, you can go through menopause without adding anything. Um, I think um, I think more the thinking is that we had offered hormones to help with women who were really struggling through the transition of menopause or into menopause itself. And then in the early 2000s, I know we talked about this the last talk we did, but in the early 2000s, the data seemed to point towards an increased risk in breast cancer with hormone use. And so basically, from a clinical perspective, that tool got almost entirely removed from
Hmm.
the toolkit for a lot of providers, just would not touch it. And so women who really, really suffer with horrific night sweats, they're a professional person that I'm just creating one, like, one one image for you, but that's just in front of people, that needs to be able to be in front of people, and is literally like just sweating and completely dripping. I mean, there are women that have absolutely horrific vasomotor symptoms, whether it's night sweats and they're drenched in the bed and they have to get up, change the sheets, it's so wet, or hot flashes. So I think, no, it's not absolutely necessary to use
Hmm.
hormones. I think more the idea that we want to kind of promote is that they are a good tool, and we've kind of come full circle,
Yep.
and everybody is now recognizing that like what we once thought was harmful about them is mostly not actually accurate. And so they are back on the table as an option, and yet the public perception of them has still been really, really scary. And a lot of people, I think, have it in their minds that hormones equal breast cancer and they're bad and you should never do them.
Hmm.
And so I think it's more about not that everybody needs to take them, but just that if you are struggling in a really significant way, they are a tool that can be so, so useful.
I will say one more thing, and actually, Allie is someone that kind of brought this back to my attention a few weeks ago when we were talking about this. One deciding factor should be if you are sexually active with somebody that has semen that is active with sperm, you need to remember that, like, during that perimenopausal period, when your periods are changing, you can still get pregnant until you are 12 months without a cycle. And that can be really hard to tell for some women. So, like, that could be a deciding factor for people. If I have folks that are missing periods but are definitely not in menopause, hormonal contraception is usually a good fit for them, because with irregular periods, it can be a lot harder for people to know when they are actually fertile. Um,
Okay.
okay, what else?
We
What next?
missed we missed one on oh, I'll do this one from Kelly. The AG1 layered superfood, is that considered a multivitamin? And I do add B vitamins. So I think I actually don't know anything about the quality of AG1. I've looked at the label because patients bring it in all the time and ask me to look at it. And the forms of the vitamins that are on the nutrient label look pretty good to me, and I don't usually have anything bad to say. I say, yeah, this looks like, if it has in it what it says it has in it, which I can't speak to that, but if it does have in it what it says it has on the label, then I think it's a good kind of um cover your bases a little bit. It's not a really like big high potency multivitamin, but I think it's an okay place to start. And then I am really a big proponent of extra B vitamins, so
Yeah.
I don't think it has high enough amounts of that in and of itself, but it gives a little bit of all the things. So it just
Yeah, and
maybe.
I want to add on to that. When you see a supplement like that and you turn it around and it has like 45 things on it, you do have to remember that if you're taking a scoop or like a few capsules of that, you're really not getting a lot of each one of those things. So as much as I would do anything that Laird Hamilton tells me to do, I still wonder about, like, if you're just covering your bases as like a multi, I think it's probably awesome, honestly. But if you're starting to use it for more targeted things, I would probably shift you more towards a different type of nutrient. I think we should talk about sleep, that there have been a couple more things about sleep. So I do want to address this because I'm a notoriously bad sleeper. So I am a nitpicker about sleep with my patients who are perimenopausal and menopausal because it has such a huge impact. And I know, Taryn, you had a question about brain fog, and I actually think this is a big piece of the puzzle. I really, really think disrupted sleep is a huge piece of our brain fog issue. I think that our sleep deteriorates for a lot of reasons. As though some basic tips to think about are: number one, get a sleep study if you cannot get your sleep dialed in, or if your partner is saying that you're snoring or you're waking up gasping during the night, please get a sleep study. It's a total pain in the ass, but it's really worth it because undiagnosed sleep apnea has a lot of health risks associated with it. And metabolically, just to bring it full circle, it is very, very, very challenging to get to a good place metabolically if you have sleep apnea. Um, so some people start to have more poor sleep because their progesterone levels are dropping out because they're not ovulating as much, and progesterone can be very nourishing for our sleep. So that is something that a lot of times we will consider supplementing with. I want to remind people that moving your body, being exposed to daylight, and don't shoot the messenger, but like not staring at screens in the evening can make a really big difference for people. But I think what you do in the day is much more important. So make sure that your eyeballs see the sky, even if it's raining, and that you're like exposed to daylight in the morning. It actually has a huge impact on our ability to manufacture melatonin at night. I use a lot of supplementation for sleep in this phase. I use a lot of melatonin if you're having trouble falling asleep, not for staying asleep, but falling asleep. There's awesome data on melatonin, has great anti-cancer properties. It's a great antioxidant if you tolerate it well. It's a lovely tool. And I use a lot of herbs for staying asleep too. Like I use a lot of valerian. I use a lot of combo herbs for helping people stay asleep. I use a lot of serotonin support. So I also think that's like a whole other subject, but our serotonin production really can tank in menopause because estrogen is so important for our neurotransmitter production. And serotonin is really important for staying asleep. So I will throw on a lot of 5-hydroxytryptophan or other tools. I use a lot of pharmaceuticals at this phase of life too. If they are needed, I am great with that. So hydroxyzine, trazodone, gabapentin, like there are great medications that can help us get through this phase with sleep. You have to advocate for yourself. So I really encourage you to like brainstorm with your doctors about what is going to be a good fit for you because it depends on the severity. Um, yeah. The one other thing I do want to say about this, I see this with a lot of my working moms, is the old, I'm going to stay up a couple extra hours after my kids go to bed because it's my time. So I believe that that is like magic time for a lot of us, and it's quiet and you're not at work and you don't owe anyone anything. But the earlier hours of sleep are when we do most of our deep sleeping. And that is really important for restoration and cleansing of our brain. So I really want to remind you guys for pushing, like not push your bedtime back too late because I do think that we suffer for that a lot. That's my spiel on sleep.
Sounds good. I'm paging through a talk that I did about uh blue light and sleep and stress. And I don't think I'm going to find it really quickly here, the slide that I wanted to share. But one of the things I wanted to say is that artificial blue light, which is the stuff that emanates from computers and screens, is even stronger than natural blue light. It has a shorter wave and makes it the shortest wavelength, so it has the most energy, and it not only impacts the eye in a negative way, as in like damaging antioxidant or I'm sorry, oxidative stress to the eye, but it also makes the eyes feel like it's high noon all the time.
Hmm.
And that whole idea of, melatonin is produced at night when your eyes see dark, and then in the morning when you look at the light, melatonin is degraded by having light come in the eyes. It's one of those things that is like everybody knows it's a bad thing to stare at your phone, but it's really impressive how bad it is.
It makes me so
And
sad because,
yeah,
I love it like everybody else. What do you think about blue light blocking glasses or like, are there things you can get for your computer? Like, I like
there's
to do the crossword in bed on my computer at nighttime, which is a terrible habit.
so I haven't looked this up in a while, but there was an app that you could use for laptops. I think it's called Flux.
Mm-hmm.
That was blue light blocking screen kind of thing.
Mm-hmm.
And then blue light blocking glasses, I think, especially for some reason, if you're a lighter eyed person,
Mm-hmm.
I find that more people with
Interesting.
lighter eyes are more sensitive to the
Mm-hmm.
impact of blue light. I mean, dark eyed people could be as
Yeah.
well, but
Interesting.
especially if so. But if also if the nature of your work is computer based and you spend a good,
Yeah.
6 to plus hours a day looking at a screen, I think it's worth it to just get some blue light glasses.
Yeah.
I'm not sure we know exactly how effective that is,
Yeah.
but all things that lead to less blue light stimulation is better.
If anyone has like real tips on that, please feel free to put that in the chat. We are at 7:29 here.
We are.
Thank you guys so much for joining us tonight. I did record this and I forgot to ask anyone's permission, so sorry about that. But I will put it on Zoom and share it so that if you guys want to rewatch it or like you want to go back and think about an answer to a question, we can certainly do that.
Oh,
Um,
Can I
Yeah.
say one thing?
Yeah, please,
Really, really,
please.
really excited. Next month, March, I think it's 13th, is it? Is the, yeah, it's also going to be the 13th, but next month, March. Our topic is going to be sexual health, and we are planning to have a guest speaker that is a sex therapist that's going to talk. She works with couples
Bow, Jacob, bow,
and
bow.
with intimacy kinds of things. And she's a really dynamic person, super, super interesting. And I think a profession that's, not talked about a lot, and not a lot of people have exposure to something like that. So that'll be I think a really great one to tune into if you have the ability, and if you want to, let anybody else know about it. It should be really good.
Yeah, and one other thing I do want to say, I will email everybody a reminder, those MailChimp emails. Please feel free to let me know you don't want to receive email like that. That's fine. I'm not like I won't market anything to you, but you can respond to those reminders if you want. If you have like questions or topics that you think would be fun to address in here, please feel free to share some feedback with us. And that's it.
Yeah.
Nice to see everybody.
Thank you.
Good night. Sleep tight.
Bye.
Thank you.
Goodbye.